Hello everyone. In this video, we'll be learning about ultrasonography of different superficial soft tissue masses. So this is taken from one of the RSNA article of 2022. So we know that ultrasonography is excellent imaging modality. We come across many superficial soft tissue masses in our everyday practice, and we use ultrasound as a most common diagnostic modality because of easy accessibility, high spatial resolution for the superficial soft tissue masses, and it also allows real time imaging. But the disadvantage with the use of ultrasonography of in soft tissue masses is with the deeper ones, where the image resolution is less. So deeper soft tissue masses we have to go for MRI. So before knowing about the different superficial soft tissue masses, what is the demarcation for superficial and deep soft tissue masses? So superficial is the one which is present in the cutaneous and the subcutaneous plane, whereas deep to subcutaneous tissue will be the deep soft tissue masses. Coming to the most common soft tissue mass which we see in our everyday practice is a lipoma. So it is a most common soft tissue tumor made up of mature adipocytes, and it is having a pseudo capsule. And even though lipomas are superficial, sometimes they can be present even in the deeper tissues, that is in the intra and the intermuscular planes. And on ultrasound, usually they'll be iso to hyperechoic. And in this study, we can see most of the cases, that is about 59% were isoechoic, whereas 26% were hyperechoic. And we know that pure fat is anechoic, but because of the presence of the connective tissue and other reflective interphases, there will be echogenicity within the lipoma. And also we can see a fine curvilinear, gently curved echogenic lines which will be parallel to the skin surface, and these are characteristic of lipoma. This represent a fibrous septae, and when we put on a color Doppler, this lipoma doesn't show any internal vascularity, and rarely it can show a septal vascularity which is minimal flow. And the differentials would be asymmetric fat deposition, but this will lack a pseudo capsule. And the others can be a angiolipoma, which is a variant of lipoma, but this will be hypervascular. And in summary, lipoma will have a oval, and because it's a fat, it is compressible, iso to hyperechoic soft tissue mass with a linear or gently curvilinear reflectors, that is fibrous septa within the mass, and doesn't show any vascularity or sometimes minimal septal vascularity. These are characteristics of lipoma. So in this image we can see a case of lipoma which is oval. We can say it's almost isoechoic to hyperechoic, and fine linear curvilinear septa we can see which are parallel to the skin surface, and this will be usually compressible. The next one will be the epidermal inclusion cyst, and this is most commonly seen in the hair bearing areas in the body, that is in the head and the neck region, trunk and the scrotum region. And less commonly we can see these in the extremities, and more commonly seen in men, and these are also known as infundibular cyst or epidermal cyst. And the name itself says that is epidermal inclusion cyst will have a fibrous capsule lined by stratified squamous epithelium, and lumen will be filled with the keratin debris. And based on their origin, they can be congenital or acquired. Congenital ones will have a will be formed by the trapping of the displaced embryonic epithelial rest, whereas the acquired epidermal inclusion cyst will result from the obstruction to the drainage unit of the pilosebaceous unit, or there can be any implant fragments of the epidermis in the dermis after a penetrating injury or an injection. And there is one syndrome which is associated with multiple epidermal cysts, that is Gardner's syndrome. And on ultrasound we can see ovoid and mildly hyperechoic lesion which we can see here. This is epidermoid inclusion cyst which is also again oval, which is mildly hyperechoic. In this image we can see it is heterogeneous with predominantly hyperechoic pattern, and it will show uh, through transmission through, that is posterior acoustic enhancement, and there will be internal heterogeneity. This is characteristic of epidermal inclusion cyst. It will have low echogenic areas, scattered areas of bright echoes and anechoic clefts. Rarely we can see calcification. And one more important thing is there should be a dermal involvement, that is more than 50% of the dermal layer should be involved, and there should be a focal hypoechoic region. As we see here, there's a focal hypoechoic region which is extending into the epidermis, that is known as submarine sign. This is seen in epidermal inclusion cyst, and this is one of the characteristic. And when this get infected or ruptured, it will appear more lobular, and there will be increased flow on color Doppler. Usually the differential for this is a pilar cyst or a tricholemal cyst, and this can be differentiated by its location and the absence of connecting tract to the epidermis, that is the submarine sign will be absent. Coming to a fat necrosis, this will have a vascular, this will be caused by the vascular impairment or trauma. But in some cases there won't be any history of trauma. Instead there will be history of surgery, injection, autoimmune disorders or vasculitis, or any sickle cell diseases. And on ultrasound usually there will be ill defined and hyperechoic, avascular, and they'll have a poor margins. The margins are not well defined, and the differentials will be cellulitis, which will have a cobblestone pattern, and subcutaneous panniculitis like T cell lymphoma, which may appear as hyperechoic infiltration or nodule. And wait, we'll see about the here we can see a fat necrosis. We can see how they are very ill defined and hyperechoic, and they do not show any vascularity on color Doppler. And history is very important in fat necrosis. Coming to peripheral nerve sheath tumors, these are the true neoplasms, and they are divided into schwannomas, neurofibromas, and malignant peripheral nerve sheath tumors. These are, we know that schwannomas contain Antony A and Antony B areas on histopathology, and they will be 100 positive on immunohistochemistry. And there's something called as ancient schwannomas. Ancient schwannomas are nothing but the degenerative schwannomas. Means old schwannomas which undergo degeneration, which include calcification, cystic foci, or with bleeding, fibrosis, hemorrhage. These are known as ancient schwannomas. And it's very difficult to differentiate schwannomas and neurofibromas in ultrasonography, and both will be most commonly seen in schwannomatosis and NF1. And in ultrasound there will be homogeneous and hypoechoic with increased posterior acoustic enhancement. And the most important and one of the pathognomonic, if you see this sign in ultrasound, it is 100% sure that this is a peripheral nerve sheath tumor, that is there's a direct continuity with the peripheral nerve. If you see a lesion like this, and when you trace the continuity proximally and distally, you can see a continuity with the nerve. This is pathognomonic for the peripheral nerve sheath tumors. And as I already said, difficult to differentiate on ultrasound alone. So there are some features which are more towards neurofibroma and some are towards schwannoma on ultrasound. Neurofibromas are usually fusiform, lobulated and hypovascular, whereas schwannomas will have a smooth margins and they are more vascular. Okay, and they'll be round in shape. Here we can see a halo with a well defined lesion with a peripheral halo and showing increased vascularity. If you want, we can comment, and on real time imaging we can see its connection with the nerve, and this came out to a peripheral nerve sheath tumor. And because of the increased vascularity, it mostly goes towards schwannoma. And there's no, usually there won't be any differentials if you see a nerve continuity, but if you don't see any continuity, then you can give differentials with other benign and malignant masses. In this image, you can see a peripheral nerve sheath tumor. Here you can see how nicely it is continuing with the nerve proximally and distally. That is entering and the exiting nerve can be seen here. And that's it for today's class. And I'll be talking about other superficial soft tissue masses in a part 2 of the superficial soft tissue masses. Thank you.